Hello, I'm Bobby Jean Schweitzer, and I will be presenting Gastrointestinal and Hepatic Systems Part 1. So the lecture module will consist of types of liver disease and laboratory tests. So let's start with types of liver disease. And we'll start with a question. A 58-year-old male is scheduled for a total knee arthroplasty, and he has a history of cirrhosis. Which of the following predict a significantly increased risk of perioperative complications? A. Alkaline phosphatase level of 200 milligrams per deciliter. B. Spider hemangiomas. C. A bilirubin of 3.5 milligrams per deciliter. D. An albumin of 3.6 milligrams per deciliter. Or E. A history of easy bruising. So the diagram there is the Child-Pugh Classification and should give you some clues that the correct answer is a bilirubin of 3.5 milligrams per deciliter. You can see bilirubin that is greater than 3 results in a Child-Pugh finding of a class C, and a C carries a higher risk than A or B classifications. And we'll go over some of these other tests during the lecture. So why is A correct? It's because a bilirubin of greater than 3, as I indicated, or as I noted, indicates Child-Pugh C. Class A is incorrect because alkaline phosphatase levels do not predict outcomes and are not a component of either the Child-Pugh or the model for end-stage liver disease or MELD scoring system. Class B, answer B is incorrect because spider angiomas do not predict outcomes, and also it is not a component of either Child-Pugh or MELD scoring. Answer D is incorrect because an albumin level of 3.6 is normal and would make the patient a Child-Pugh A. Answer E is incorrect because bruising is nonspecific, is a poor predictor of bleeding in general, and is not a component of either scoring system. So hepatic injury, hepatocyte injury and diseases can be secondary to viral infections, autoimmune conditions, alcohol, hypoxic hepatitis, drug-induced liver injury, steatohepatitis or fatty liver disease, biliary obstruction, cirrhosis or scarring of the liver, hemochromatosis or iron deposition in the liver, neoplasms, or cholestasis. So let's talk a little bit about drug metabolism and liver injury. The CYP or cytochrome P reactions generate metabolites that are highly reactive and potentially toxic. These can cause or aggravate liver injury. Zone 3 hepatocytes have the highest density of cytochrome P450 proteins and are the most susceptible to injury. These are susceptible to injury from drug metabolism, oxidative stress, severe hypotension, or hypoxia. Central lobular necrosis is the classic acetaminophen or Tylenol-induced injury. CYP2E, which metabolizes acetaminophen, is in zone 3 of the liver. So risk factors for liver disease include alcoholism or excess alcohol use, sexual promiscuity with exposure to hepatitis C and HIV, illicit drug use, again causing direct injury from toxins that are injected, as well as HIV or hepatitis C, blood transfusions, exposure to hepatotoxins such as excess acetaminophen or alcohol, prior jaundice, and genetic diseases such as alpha-1 antitrypsin deficiency or hemochromatosis. So cirrhosis is a chronic disease. It occurs when normal hepatic tissue has been replaced by fibrotic scar tissue or hypertrophic nodules. It's a progressive loss of liver function and development of portal hypertension. The most common causes are alcoholism, followed by viruses, metabolic disorders, and all have a similar pattern of fibrosis. A cirrhosis is clinically silent until about 70% of the liver has been destroyed. This is due to the substantial physiologic reserve of the liver. Portal hypertension only develops after depletion of this reserve. Typical symptoms of portal hypertension include anorexia, nausea, vomiting, abdominal pain, weakness, jaundice, spider nevi, ascites, splenomegaly, a firm or hard liver, esophageal varices, and encephalopathy or coma. Encephalopathy is due to elevated ammonia levels, and the cognitive deficits can be either coma, delirium, dementia, or asterixis. Terminal events in patients who have cirrhosis are usually secondary to massive hemorrhage, renal failure, sepsis, coma. The clinical assessment starts with just symptomatology. The mild nonspecific symptoms of liver disease include loss of appetite, easy fatigability, malaise, and sleep disturbances. More specific symptoms include pruritus or itching, jaundice, abdominal pain, particularly right upper quadrant pain, indigestion, and changes in the color of urine and stool. The urine gets dark and the stool gets light. So this is the Child-Pugh classification. We showed that briefly with the question. Patients are classified into levels A, B, and C. A is mild disease, B is moderate disease, and C is severe disease. One needs to look at five different components. Bilirubin, and if the level is less than 2, that's an A, 2 to 3 is a B, greater than 3 is a C. Albumin levels, the higher the level, the better. So a normal level of greater than 3.5 is an A, mildly decreased albumin levels of 2.8 to 3.5 is a B, and severely decreased albumin levels less than 2.8 is a Child-Pugh C. The prothrombin time, as measured in seconds, contributes. A slightly abnormal or prolonged prothrombin time results in a level A. A more moderately prolonged prothrombin time of 4 to 6 is a B, and severe prolongation of the prothrombin time greater than 6 seconds is a C. The presence or absence of ascites and encephalopathy are the last two components. These have been criticisms of the Child-Pugh classification because these are subjective. But if there's no ascites and no encephalopathy present, it's an A. If there's slight ascites and minimal encephalopathy, it's a B. And when there's more moderate ascites and more advanced encephalopathy, it's a Child-Pugh C. The alternative to using a Child-Pugh C is to calculate a MELD score. MELD stands for Model for End-Stage Liver Disease. This is the formula. Most people don't get out their calculators and plug in these numbers. They go to the web and they just Google for MELD or MELD calculator and then enter the numbers and push the scoring button, and one will get a value. One needs to know a creatinine level, a total serum bilirubin level, and the INR to be able to calculate a MELD level. The higher the MELD score, the worse the cirrhosis, and the higher the risk. Minimum values for all of these numbers are 1. So if the creatinine is 0.7, you enter 1. The maximum value for creatinine is 4. So if the creatinine is 8, you still only enter a 4. So the MELD score was originally developed to predict mortality within 3 months for transjugular intrahepatic portosystemic shunts, better known as TIPS procedures. But it is now used by the United Network for Organ Sharing, better known as UNOS, to prioritize patients for liver transplants. The MELD score predicts 3-month mortality in hospitalized patients. A MELD score of greater than 40 carries about a 71% 3-month mortality. A MELD score of 30 to 39 carries a 53% risk. A MELD score of 20 to 29 is 6% risk. A MELD score of less than 9, only about a 2% risk. The MELD score of 0 to about 15 corresponds to a Child-Pugh A. From about 15 to 30 corresponds to a Child-Pugh B, and a MELD score greater than 30 corresponds to a MELD score of a Child-Pugh of C. And again, a MELD score of less than 15 is considered mildly elevated risk. Moderate elevated risk is those MELD scores between 15 and 30, and MELD scores greater than 30 carry a very high risk of both mortality and perioperative morbidity. Let's talk a little bit about specific laboratory tests. So let's start with a question again. You are scheduled to provide anesthesia for an endoscopic retrograde cholangiopancreaticosis retrograde cholangiopancreatography, or better known as an ERCP. No wonder we call it an ERCP. For a patient with a common bile duct stone causing blockage, which test is most important indicator for hepatic excretory function? A, an albumin level, B, a bilirubin level, C, an alkaline phosphatase level, or D, an aspartate aminotransferase level, or AAT level. And the answer is bilirubin. So answer B is correct because bilirubin is both conjugated and excreted by the liver. Answer A is incorrect because albumin is synthesized by the liver but not excreted in the bile ducts. It's delivered directly into the bloodstream. Answer C is incorrect because alkaline phosphatase is excreted by the liver and excreted through the bile ducts, but is also released from bone, so it's not specific for liver disease. And answer D is incorrect because it is released with hepatocyte inflammation and injury, not obstruction. The alkaline aminotransferase level is released with hepatocyte inflammation and injury, not from obstruction. So specifically, ALT is an alanine aminotransferase, and this is elevated with liver disease and injury. It was formerly called serum glutamic pyruvic transaminase, or SGPT. Aspartate aminotransferase, or AST, is elevated with liver disease and injury. This was formerly called the serum glutamic oxaloacetic transaminase, or SGOT. Bilirubin is elevated in patients with injury, hepatocyte injury and disease. The PT becomes prolonged, and therefore the internationalized ratio, or INR, becomes prolonged. Hypoalbuminemia and thrombocytopenia, or low platelet counts, are both occur in patients with advanced liver disease. Transaminases, a mild elevation usually occurs when there's mild injury to hepatocytes. A mild elevation is typically defined as between 100 and 249 international units per liter. This can occur with fatty liver, medications, moderate or binge alcohol consumption, hemochromatosis, cholestasis, or gallbladder disease, chronic viral hepatitis, neoplasms, and cirrhosis. Moderate elevations of AST and ALT, or transaminases, are defined by levels of 250 to 999 international units per liter. These occur in the setting of acute viral hepatitis, drug-induced liver injury, flare-ups of chronic liver disease, such as viral hepatitis or fatty liver disease. They often reflect acute hepatitis that is superimposed on chronic active liver disease. More extreme elevations of transaminases occur with levels as high as 1,000 and above. This is usually due to massive hepatic necrosis, fulminant viral hepatitis, severe drug-induced liver injury, such as from an acetaminophen overdose, shock liver or hypoxic hepatitis, from extreme hypoxia or hemodynamic perturbations, autoimmune hepatitis, or acute biliary obstruction. Thank you very much for your time.